But another thing that I've heard stated and written in papers is that there to date have been 5 to 6, depending on when it was written, cases of ectasia after smile in the literature. We know worldwide that there have been 750,000 cases done roughly, so the incidence is
2 million.
6 out of 750,000. Where we know that there's an incidence of 6 out of 7,000 in one site. So don't...
But that's abnormal topography.
It doesn't matter. What I'm saying is anyone who thinks that every ectasia case after smile has been published is misguided.
Yeah, you will see more cases.
You'll see more out
and
there.
And the concept that smile is stronger than LASIK is not correct, because the screening criteria has to be the same for LASIK and smile.
In 10 years, we have not had a single case, and it's been more than 9,000.
I think what Sheetal and Dr. Sri Ganesh...
We've never taken such chance.
Yeah, all of you are saying is, in the initial phase of any new technologies, like I showed you that advertisement of the watch, there is a tremendous amount of different versions of propaganda of different types of techniques. And sometimes we just, at that point of time, nobody's right, nobody's wrong. It's just that somebody is saying this is how it works, and we all fall for it. And in the initial phase of it, it was told that this is stronger than PRK, it is stronger than the biomechanics is different, but now everything is kind of coming back to
Of course, these cases started coming
but
up
what has
after
to be
3 years or 4
understood
years.
is biomechanics in a normal cornea is different from biomechanics in an abnormal cornea, and it's not that smile offers any protection against these abnormal corneas. But if the biomechanics is better, then you may have long-term better stability and less regression long-term if your biomechanics is better.
But Rohit, I don't think we should go away with the feeling that you can do smile extra in these borderline cases. Because I don't think that smile extra also
we'll be publishing that because it's a large data and we have a 4-year follow-up. So,
but at the moment, remember,
again we are falling into the same trap of going away with a feeling that you can do
with 4 years of smile.
Borderline cases by just adding an extra to it, when it is not proven yet.
Yeah, so that's, I think,
When we do smile extra, we do see a demarcation line. Now, I don't know how significant it is, but we do see a demarcation line, and we have seen less biomechanical changes
but I don't know
in
how
smile
we would,
extra group versus smile.
Sheetal, how can we not have any refractive error change and have only the beneficial effect
because
of
we are not doing the Dresden protocol.
Progressive flattening like a epi-off procedure.
Yeah,
it's
but
just
then
flash
if it
cross-linking.
is not doing what it is supposed to do.
It does what it's supposed to do.
Yeah, because but how can it not change the refractive error?
See, with regular cross-linking, Dresden protocol, epithelial off, 400% increase in corneal strength. We don't want 400% increase because we are not treating keratoconus. We just need a safety belt.
These are those patients where
these are borderline cases.
Borderline in terms of
hovering on to keratoconus.
The
first we have to define what is borderline.
They are not hovering. They are not hovering on keratoconus. You don't know. This is the discussion we had.
Just because we are doing smile, we should not lower our guard and be.
I don't think we should go away with that feeling that you can do an extra and get away with it.
This is like how you have a final D value of, say, more than 1.65 but less than 2. It's not red but it's yellow.
So once your paper gets published, I think there'll be more debate on this. We'll move to the next one about, again, this is one more thing which was initially told to us, that there is no dryness because there's no nerve cut. The question I want to ask here is dryness only related to the cut of the nerves on the flap, or there is more other factors?
Go ahead. Dan Reinstein has cured this completely. He does smile, fine. Is there a problem? He gives the patient the bill and they start crying.
So, do you think, Dr. Ramurthy sir and all of us, do you think that there is less dryness in your smile patients?
I think
Dr. Gaurav?
Theoretically we would believe that there should be less dryness because less nerve fibers are getting transected. But what we have found is that maybe in the initial 1 month or so, smile has an advantage. But after that, the findings both with femtolasic as well as smile is almost exactly the same. There's not much of an advantage that smile offers over time as far as dryness is concerned. But if you're talking about day one post-operative comfort of the patient, definitely the patients who have undergone smile are feeling much better, more because
Yeah, I
the
agree with
amount of
your
transaction is somewhat smaller.
Dr. Cordelia, do you think in Singapore, when you were doing smile, you had patients less complaining of dryness compared to the LASIK group you have treated?
I think just now in my talk,
She mentioned.
I mentioned this effect of dry eye on smile. Initially, well, to be fair, I think patients probably have less dry eye, but my smile patients are more fixated on their visual recovery, and so it offsets whatever advantage you have with the dry eye in the first few months. After 6 months, all studies more or less affirm that there's no difference between smile and LASIK. But within the first few months, perhaps smile patients are less symptomatic of dry eye, but they are probably wondering why their visual quality isn't so fantastic. And so that's why, that's the main contention.
I'll be loud enough for people who did not hear. So basically she says that initially they're more worried about the outcome of the quality of vision, but in 6 months' time, everything gets the same, right?
So Rohit, I'll just...
I think it's... Gaurav, I think, wants to say something.
Yeah, what I wanted to add was that it's not just, if we leave aside vision for a moment, overall smile patients post-op in the first week compared to our LASIK patients are much happier patients as far as the symptoms are concerned, less dry eye. Even otherwise, they are probably the happier patients in every other way. And, what we've realized is like visual recovery, yes, Dr. Chan says, but, the number of patients who have those visual symptoms has gone down so drastically now. It's in the first couple of 100 eyes where you would probably have more patients who would be more bothered by the vision. But over a period of time, it tends to improve. So dry eye is what we're discussing. I think definitely smile patients, dry eye and their general symptoms post-op or comfort post-op on day one is much better than the LASIK.
I don't agree with you mentioning the first 100 eyes being a problem, because I've mentioned in my talk just now, the learning curve is not an issue, at least in our cohort.
No, your data stands out quite, different from everybody else, and I believe your data because, it's been discussed again and again, it's very scientifically done. I'm not disputing that at all. It's just my experience that from my practice is what I...
We talked earlier how important it was when we look at studies to make sure they're comparable. I think it's humorous to hear Singapore and India discuss dry eyes in an environment that has 90+% humidity.
Yeah.
Come to Arizona and see what the results will be. Seriously, I've been to Singapore. It is the most humid place. I don't doubt you don't have much dry eye problems after refractive surgery.
Yeah, the dry eye is an unbelievably complex disease that we are terrible at treating or managing or understanding. Now we throw in a laser ablation with tissue removal, and we think that it's going to be simple with this, but it's simply not. The patients that are going to get dryness that, I don't mean this in the wrong way, but I don't care if someone's dry for a month. And they won't care at 3 months. They'll care for those first 2 visits, but they won't care at 3 months that they were dry for a month. I care about the people who are actually clinically significantly dry at 6 months and not seeing any end in sight. And that's where we need to know if there's truly a difference between procedures, especially difference in procedures for specified patients. That's what we'd really like to know. And I don't know that I've seen that yet, anyway.
Michael, I just want to add to what you just said. Although we live in Singapore, we're in a very humid environment, but we do see a lot of dry eye patients, and that's because we're in an air-conditioned environment all the time. Yeah, so it's really freezing cold indoors. Okay, so
Rohit, if you look at the long-term dry eye, patients coming back, maybe like after 3 years, 4 years, 5 years, definitely, because I've been doing LASIK from 20 odd years and then SMILE from 7 years. I see that the number of patients, the long term, over 1 year, people coming back with symptoms of dry eye are more with LASIK than SMILE. Even my case, I never had any dry eye. My eyes were perfectly normal. I couldn't feel my eyes. But after LASIK, if I do a long list, if I'm in the air-conditioned room for a long time, it becomes a little sore. I can feel the soreness. I feel my eyes. So definitely LASIK, I think long term, it's 3 years since I've had LASIK. But I think long term also, there is a difference. It may not be a huge difference, but there is a difference.
I think we'll move to the last part.
Just a,
There are
We've done
studies,
for
but they
25
haven't showed
patients
We have
for
also
high
done
myopia, and we found this difference in all respects. And we studied them till 1 year. So
The
it is definitely having a better profile.
evaporative dry eye is more. The tear secretion is normal if you do a Sherman's, but the T-butt actually is better.
No, even
with smile.
subjective completely.
Tear
Subjective
osmolarity also. Tear osmolarity.
The issue is also whether these patients have undergone a dry eye workup as they should be before the surgery.
sir.
Yes.
And many a time, I'm sorry to say that most refractive surgeons will only look at the refractive maps, the topos, the tomos, and go ahead. And the dry eye part is neglected. So I've seen patients who had pre-existing dry eye who have been missed, and then it skews your post data.
See,
Because
No,
if
so
your-
these were
if a
patients
smile
in study
surgeon-
environment.
If a smile surgeon has looked at it very carefully and has eliminated those or treated the dry eye, he will not have so much dry eye post-op. A LASIK surgeon who is less careful will have more dry eye post-op. So
We
that
always
needs to be looked at.
screen for dry eye, and we do the dry eye test.
That's what I said, but
pre-op.
not everyone is
But
as
we
careful.
we have two groups. We compared femto LASIK and SMILE, and definitely there was a difference in the T-butt and the tear osmolarity between the two groups.
And this was contralateral study that we did for 25 patients, high myopic treatment.
Sir,
So it's like a bang-on study.
so some patients, when most of the studies have the same tear film metrics in both the eyes, and when you do one procedure to the other, so the eye should behave also the same way. So if you are taking two groups of patients or two different subsets, then probably you can debate. This is like the same patient, so yes, Dr. Anagar. If you have both the procedures and the patient, which one would
In
you?
both, we would improve the tear film first.
I think the criteria should be the same.
We would treat the dry eye, improve the dry eye, and then do the procedure for either procedure, whether it is LASIK,
is there any
but if it is
cutoff?
mild dry eye, if it's moderate to severe dry eye, then I wouldn't do a corneal procedure, I
Either,
would do a
correct, I
phakic IOL.
No,
So that's.
what I'm asking you, sir, is a specific thing, whether you would do SMILE in any scenario and you would not do LASIK.
No, so that's what Dr. Sri Ganesh is saying, that if you have a dry eye patient, you're not going to choose one over the
Either,
other.
yeah. So there's
And there
not
is no
going to be any
cutoff. You
difference.
have to treat. And if it is moderate to severe, you would go for phakic IOLs rather than doing a corneal procedure.
And the other thing is, even your refraction can change
Definitely.
with dry eye, if it's moderate to severe dry eye. So it's very important to first optimize the ocular surface even before doing your refraction.
And now you have different options of LipiFlow, iLight, and all these machines where you can do it before your procedure or you can do it afterwards. It's not about just restraining yourself just to the drops anymore. The last part of the talk is about, we have moved on from SMILE.
Rohit, just one question. We've been having a discussion there. Of late, suddenly, aren't we, a lot of people talking about dry eye? Now, is it, three questions. Is dry eye increasing?
We have it in the afternoon.
Okay. Or is it the machines pushing us to look for
Listen,
dry
evidence
eye?
versus eminence. So, the last part of the talk is about, we've spoken about topo-guided treatment, we've spoken about the SMILE. I think one of the most important thing which we all started with was the wavefront guided treatment. The wavefront, I think Dr. Ramurthy was one of the pioneers of this from the Zyoptix, and you were also there. Then afterwards, the wavefronts became difficult to capture images. So what happened was, we went back again to the topography because at that point of time, Alcon did not have they had a Clinix system, it didn't really work. So we are coming back again. Many companies are trying to bring back, and I think next year Alcon is also bringing a ray tracing, which is nothing but wavefront guided treatment. So it's going to, so that Contura may be replaced by a wavefront guided treatment.
Why they're not happy with Contura?
I don't know. That I think he should say. He's part of it.
It's going to be a combination of wavefront guided plus topo guided.
This is exactly what Zyoptix is.
And
So-
even Schwind has that. They have both topo guided and wavefront, and there were nomogram where you decide whether you're going to do, so even Zeiss has it.
So basically, the wavefront guided treatment is not something which is going to be outdated. I think every big companies are coming back in a different route or a different road. So I feel one of the great use of wavefront guided treatment is in a case like this. This is a case operated in a different part of the world, but he's come here. But it was a smile surgery. And if you see that there is a small change of, it looks center, but it's a very, very small superior decentration here. And I don't know the surgeon, I don't know the parameters, I don't know. He just knows that his power was -8 and -1 was his cylindrical power. And he's very, very unhappy with this quality of vision. And he says that his vision and his refractive error. So I'll just open up everything. So I just wanted to show that there is a tremendous power of using a wavefront guided system in today's world. I'm just showing a abnormal cornea. You can bring that also here. We don't need the topography anymore. If you can bring this also here. Perfect. If you bring this here, this is his, he's very unhappy. This is his vision. He's reading 20/20. If you look at his refraction, it's just around 0.25. Very minimal cylinder on subjective, around 1.5 diopter. And he feels it is very uncomfortable. So when you use a topo-guided treatment, there's very little you can actually study, except cornea, even though that's the reason I asked in the morning, Professor John Marshall and other people, that the word wavefront is completely wrong there. It's not a wavefront at all because there's no wave there. It is just an elevation aberration. This is a true wavefront because you have a light going in and coming out. So you can see that it gives you multiple plots. And if the best plot for me is if you go to that higher order PSF, you have this coma. And one thing which is very unique about a lot of this, when you use a wavefront guided treatment, you can actually sit and see which of this aberration actually helps you to get you the best outcome, even though you may not be able to use it. For example, if you click this on, this is very interesting. This is why I want get Damien to talk about it, because he has a different aberration than Zernicke. We assume that if you knock a few on, you'll get a better outcome. But if you see that if you knock a few on, it's getting worse outcome. So it's becoming better. If you knock the vertical coma, it's getting even worse. Now it becomes best. So, and you can keep some, so you can play around with this. So virtually there is a machine. The reason I put this picture is the machine, I think, has a very, very thinking system which plays around what needs to be corrected and what needs to be avoided. And I'll just finish it, then we'll have a discussion. And then you say that you want to transfer this image, and you can just play around it the whole day, and you know that. So I want to ask you here, for this kind of a cornea, click it on, with such huge assay, with no refractive error, how would your aberration profile, which you have designed now, which you say it's much better than Zernicke, really helps you?
Yeah, there's like a big flaw in the Zernicke is that the separation between what's called the low order aberration, which is ferrocylindrical correction, and the higher order aberration is wrong. I can show it very easily there without any mathematical equation. If you see here, this little bump here is defocus. That is, the bump should not be in any higher order mode. Similar here, you see this is secondary astigmatism. It's not pure high order astigmatism, it's high order astigmatism and some low order astigmatism. But it's not negligible at all. If you come back on the previous slide with the refraction, can you show again the difference between subjective?
Summary.
Go back there, right. You see the subjective refraction is very different from the Foropter Zernike computed refraction. Because of this artifact, you see the patient is not myopic, but if you go to the Zernike, for different diameters, it predicts defocus. Why that? It's just to compensate for the wrong defocus, which is coined in the Zernike spherical aberration, and hence the new basis we've developed, it was my PhD, maths PhD program, the core of it, is a series of functions that for the higher order are devoid from low order modes. Now go back to the point spread function, please. And if you think about it, this kind of point spread function is not realistic at all. With this point spread function, which is supposedly the higher order vision of the patient, the visual acuity should not be more than 20 to 100. Because this point spread function contains myopic error, and it's wrong. It should be like a crisp central point with like a little faint blur halo around it, so that the patient can see 20/20 but suffers from the halo and the things.
He says he's reading 20/20 and better, but he says that he's seeing with the shadow. But very interesting thing here is, he says that he never has any night vision problem. And that's why there is a very nice part of this, which is very useful, very little used in many abrometer, is how does your pupil affect your state of your refraction. For example, if your pupil is 3, the refraction at that is, I think the blue is around 0.75 or whatever, or 1. And you can see that till the pupil is around 7 millimeter, it is absolutely stable. That means that he's right. He says that he has no problem. But there are patients who say that they have night myopia. There was somebody who asked about night myopia in the group. How do you check for a night myopia? And this is probably one of the best, because if this patient, if there was a night myopia, his -1 would drop to -3 when the pupil reaches 5 millimeters pupil. And we have one case we'll show you later. But if you use this patient, assuming that he's just a 0.25, would you treat him for -0.25, or you treat him for that -1.25, which is in the summary?
I think that's, again, it's a wrong assumption based on artifactual Zernike mathematical issues, as the subjective refraction demonstrates. That is, it's critical that if you do wavefront-guided treatments, you should stick to the wavefront and not try to mix your own subjective refraction with that, at least with the Zernike, and that's a major issue which has led to many problems and discussions among surgeons, and I'm just not even covering the presbyopia field.
No, we'll go to the treatment. You tell me, how do you treat this?
I would treat the wavefront, and that's it.
She's going to go to that now.
I would keep the cylinder and the sphere of the wavefront and
This
treat
one?
everything there. Yeah.
This is the treatment. Zyoptix HD. See, it's very interesting. If you go to the ProScan, if you're treating this patient for a regression of power without actually looking at this part, the machine would treat something like that. There's a huge red area out that. And if you just click on this one, yeah, you can see that the ablation pattern completely changes or you can even keep, I don't think you can keep 0 here. So you can look at the subjective and what the aberration thing is. Which one do you treat? Because
if I treat the wavefront, I stick to
the second one. That's the wavefront. This one?
Has a decentration, superior decentration.
Yeah, it depends on the laser setting, but if there's no compensation in this spherical aberration, and if I would treat, the goal is to flatten the wavefront somehow. So if the wavefront carries the refraction, you just treat the wavefront. But if the wavefront is expressed differently with subjective refraction and higher order aberration in a tricky way, I wouldn't really treat the subjective refraction.
Basically, what the discussion we wanted to bring in here is, or debate here is, there is still a big need of wavefront guided treatment in our system. You know, just the topo guided in this, I don't know how much it will work because it's the lens also is creating some issues.
When you refract,
Rohit,
when you refract the patient, he has no high order aberration compensation. So the cylinder he chooses subjectively is probably affected by the level of coma trefoil that he sees. If you would now, with some magic spectacles, remove that coma and trefoil, the cylinder would change directly. And then that's why I'm saying, if you correct, at least for the astigmatism, if you treat high order wavefront aberration, you need to rely on the wavefront computed astigmatism. If you don't treat high order aberration, it's better to treat subjective refraction because subjectively, that's what the patient's preference is to be treated.
If you go back to the topography, you will see that it's a decentered, it's a decentered lenticule. It's a decentered, superiorly decentered
So
lenticule.
that is your topography of a same patient, of a cirrus. So we can plan the topo-guided treatment on that side and wavefront on this side, and then we'll see.
No, this is a problem which has occurred post laser vision correction. So obviously it's a corneal problem. Why not think of a topo-guided treatment? Why are you thinking of a wavefront-guided treatment? You have to just regularize the cornea and treat the residual area.
Few things which you have to consider here. If you look at it, it looks like a decentered lenticule, superiorly decentered lenticule, probably because of the surgeon has not centered properly. The patient may have moved the eye, put the suction on, didn't want to again redock, gone ahead with the lenticule extraction, and then there is a superior decentration of the lenticule. Now there are compensatory mechanisms, and we discussed that, where the lens itself, if it's a young patient, the lens itself tries to compensate for the coma.
Exactly.
But there is, in a decentration, there's more of coma. That's why the patient will
You can
notice
just see in that, if you can bring that here, we can then, the center screen is better.
So the patient will experience ghosting, more of ghosting in coma, and this is typically what we see. And the compensatory mechanism is, of course, with the lens and the epithelium also. When you have an irregularity on topography, when you have a decentered kind of a lenticule, there are also epithelial changes. So this also has to be taken into consideration
This
when you're
is
planning your
2
treatment.
years, 3 years. How old is this? 3 years, 2014. So I just want you to see this. This is, go to the CW, I think. And this is a zero ablation. I just want you to understand how each machine, with the zero ablation, the machine is ablating 39 microns of tissue. So
that will induce like a hyperopic shift if you correct that.
So what would you do? The total ablation on a Zyoptix was 43, which is
that's like empirically, as you said, theoretically, I mean, we should treat the wavefront and that's it. But because of the unexpected hyperopic shift due to the large amount of coma correction, you will have a hyperopic shift anyway. That's why most people, they tend not to correct the sphere when they do high order aberration wavefront. When I have patients who come for retreatment, I tell them, it's like when you play golf and you go in a bunker, you know the ball. The first goal is to put the ball on the green again, and then maybe we'll do a second hit to put the ball in a hole that is a pure refractive correction, but the first thing is to correct for the decentration. And sometimes you can achieve both in one treatment, which is fair, and the patient is happy. But it's, again, a case-by-case selection, and as soon as you treat high order aberration, you have to remove so much tissue sometimes that it creates a hyperopic shift, which you must anticipate.
Basically, I think we can keep discussing for the rest of the day about this, but I just wanted to understand that there are two machines doing one only on the topography and one only on your complete optics. So it depends on what you want to actually correct, a complete optics which gives you a better outcome, or just the topography which gives you the topo correction, and the lens would probably take over.
The problem with wavefront correction is if you are playing around with removing one particular higher order aberration and looking at the PSF. Now if you do that, you can't selectively, because it's a combination, finally it's a combination. If you remove one, the others also are affected and you don't know how it's affected. And even your lower order aberration also is affected. So it's highly unpredictable. If you just try to remove either only the coma or the spherical abrasion,
It
and you
will
expect
create a
the
different
others
balance.
not to get
Yeah.
affected, because it's kind of a balance, and then everything is going to change. Here, mainly, I feel it is a decentered lenticule, so you have to correct the surface, and I would probably go with a TopoLink treatment and see the result.
Perfect. Anything else? Any other questions till we break for lunch? That's because he's seeing with a lot of, he's got a lot of spherical aberration and some amount of coma, so he's seeing objects clearly, but he's seeing with a lot of scatter.
Because the cortex kind of filters out the higher order aberration, and this differs from patient to patient. Some are able to filter it much better. So vision is not only with the eye, it's also a lot to do with the cortex. And some of them are able to filter the aberrations and still read.
Yeah.
The question was the point spread function?
Yes.
Yeah, it's wrong, I must tell you. It's in the Zernike spherical aberration, you have as much defocus as you have high order aberration. That is, every micron of spherical aberration in the wavefront expression in the PSF induces, because of the Zernike analytical structure, the same amount of defocus. So the blur you see, the spread of the point spread function, is not what you would have if you would have a mode which is purely spherical aberration. That's why it's wrong. It doesn't match the visual prediction of the patient. When you do like high order point spread function and visual acuity prediction, usually it's way below the patient's visual performance, because the problem lies in the way you calculate the point spread function.
Okay, thank you all.